I am so excited to be sitting here today with Licia Coceani Paskay, who's been a true leader in the field and someone that I have personally learned so much from, and she's taught so many people around the world. So Licia, it's an honor to be here with you, and I'm so excited about your new book, New Trends in Myofunctional Therapy. So Licia, tell me a little bit about how the book came together and how you stepped in and your co-author Sabina Sacamano, how that happened.
About 3 years ago, she presented to me her Italian version of this book that she co-wrote with another author. And she said, you know, I would like to make an English version of it. And I said, that would be great. But if we do it, let's spruce it up, let's make it a little bit more scientifically relevant, let's put some updates, let's make it better. So we started this project, which lasted 3 years, and it has been very rewarding. And we involved people that I really love and trust and respect a lot on both continents, in Europe and the United States and even South America. And I'm actually very happy with the results, and so is Sabina. We wanted to write it in English just to have a larger audience worldwide. And because we think that the information that we have, it's really information that should go outside just the constraint of a country like Italy. You know, it's good for everybody, not just for Italians.
It's such an international crowd that you've gathered at the table, and that's kind of been your thing in myofunctional therapy. You are from Italy, you came to the US, you've always crossed bridges and worked across continents with different researchers, and that's really why it's so exciting to see everyone's work here together in a textbook that others can learn from. Who is this designed for? Who are you hoping is going to read the book?
This is really meant for a multidisciplinary group of people. So it's meant not just for, of course, myofunctional therapists, whomever they are, dental hygienists or speech pathologists or even physical therapists. But it's also, we wanted to provide a common language for all the professionals that are actually working with the mouth, in the mouth, with the head, and even with the body, because the mouth and the head are always, they need to be seen within the context of the whole body. We really wanted to create a book that is, it's multidisciplinary and international, so provides different perspectives, and anybody can find something useful. So from orthodontists to speech pathologists, dental hygienists, physical therapists, even vision therapists or breathing therapists. So everybody is going to find something that connects to everybody else. So that when you treat a patient, you know, okay, I'm treating the person that has these symptoms, and what you know also has symptoms that can be treated by this other professional who needs to know about what I'm doing and who needs to know how to work as a team to address the problems of the patient. So this is basically for multiple professionals.
The book is entitled New Trends in Myofunctional Therapy, Occlusion, Muscles, and Posture. Let's talk about the posture piece of this puzzle, because it's such an important element, and I know the Italians have really been leading the way. What do you have to say about how they came in and all of that?
Yes, first of all, when I used to be a dental hygienist in Italy, a long time ago, I remember attending some conferences, and they were all about the connections between posture and occlusion and oral functions. So that's when I became fascinated with these connections, which honestly I kind of discovered really only more recently. And so I was very pleased not only to keep in the book someone that was already in the original version of it, in the Italian version, but also expand the concept. And I'm very grateful in particular to three big proponents of posture in relationship to myofunctional therapy and to occlusion, which are Dr. Lombardozzi, Dr. Parodi, and especially Professor Scoppa. Professor Scoppa in particular is the one that came up with the concept of the glossopostural arena, in which the tongue really determines the posture of the entire body. So that's a fascinating topic. So I just wanted to have that in the book as well. And I hope that whomever reads the book finds it as fascinating as I found it.
You have always said in our courses at the AOMT that the tongue is the rudder for the spine.
Yes. First of all, an emphasis that we really put in the book was to explain why things happen, not just how they happen, or how to do myofunctional therapy. This is not a cookbook, but what to look when you do an evaluation of a patient, and how to work in a multidisciplinary manner. And so in doing so, we had to actually include how other professionals treat their patients who might have or do have a myofunctional disorders. Because I'm a speech pathologist, I can't do everything. I do what is within my scope of practice. I teach what is within the scope of practice of whomever is in the audience, but eventually everybody has a different take in how they help that particular patient. So the craniosteopathic physician is going to have an approach completely different than an orthodontist. And we also wanted to highlight the fact that the same structures, like the tongue, for instance, although it's not really a structure, but let's call it so, have different functions, and some of those functions have been explored, and they received more attention only recently. For instance, the importance of the tongue in sleep disorders, which forever we never thought that there was a relationship, but there is. Or as you were mentioning, the relationship between the tongue position and posture, or the tongue position and vision, the tongue position and otitis media, or reduced ability to hear sounds. So all these things are just coming into play in this book, because exactly we wanted to explain why it's important to know certain things and how they apply in all these contexts, and how other professionals deal with them.
And I love how you spell out what the patient arrived with, the diagnoses from the beginning, what the therapy was like, and it isn't just a few sessions of therapy. You talk about cycles of myofunctional therapy in terms of 10, 20 sessions. So what is your understanding about rehabilitation from that perspective?
There is a time in which you need to do therapy per se, but then the idea is to actually teach patients to make modification in their lifestyles so that whatever benefit they get from therapy is sustainable in the long run. And so we also understood that patients are in the office of the therapist for a very short period of time, and then they go home, and who knows, maybe they're not gonna do the exercises the right way, so they're gonna reinforce a bad behavior. So that's why I'm very pleased to had the support and collaboration of two amazing speech pathologists from Italy. One is Anna Di Tullio, the other one is Martina D'Angelantonio. Martina acted all the exercises. So there is a video library in which every single exercise is actually shown so that the patient can just imitate. And Anna provided some diaries, which are also included in the book. And these diaries are phenomenal. They're written and they're designed for children to follow the exercises with the understanding that the exercises are not the end of it, but it's important to acquire good habits that are going to last for life. So, and also we wanted to be sensitive to the fact that myofunctional therapy is done differently in different countries. So this is not an absolute, this is the way it's going to be. It's like, this is the way it can be done, or this is the way we do it. But it doesn't mean that they do the same in Brazil or in Spain, although the vast majority of exercises is pretty common worldwide because they are addressing the same functions, the same muscles, the same needs. So, of course, there is a certain degree of uniformity in the exercises.
Well, I have two big questions about what the end goals are. One is to repattern these habits or these muscles to create new habits, and then the awareness factor. Right. How do you, I love your ideas about achieving awareness. Any tips for therapists to help them bring that into the arena with their patients?
As usual, awareness, it's what it is, it's awareness. So you have to explain the patient what the end result is going to be. You have to include the patients, even young patients, in planning of therapy. Like, okay, this is what we should achieve. What can you do? You can give them choices. You can discuss how much time do you have, or where is the best place for you to do these exercises, or you need to focus on breathing first and then everything else. So that is a very important aspect. And this is regarding patients. Regarding therapists, it's very important to understand that although it's called myofunctional therapy, it's really neuromuscular retraining, if you want, because we have to work with the brain, and so we have to use the same techniques that are used in marketing, for instance. You have to motivate the patient, you have to keep up the good work, you have to create a new default mode in the brain, because the brain, through disease or through conditions like, I don't know, maybe enlarged tonsils, so the nasal breathing is not there, so there is oral breathing. Now the brain got a planning center. So you have to override the new planning center to create a new plan, which is nasal breathing. How do you do it? Repetition, awareness, the fact that the patient is with himself or herself 24 hours a day. So the patient needs to make the changes. But nobody succeeds alone. So therapists are just part of a team. The team includes not just other professionals, but family members, not just for children, but for adults as well. Because you need someone that say, keep up the good job, or I see that you're making improvements. So it's very important. It's very important to work with the brain as much as we work with muscles. Otherwise, we have no results.
One of your great interests has been mastication. You've written about it, you've published on the subject, you are a proponent of it, And I would love you to share what the value of that is on other systems, etc.
So everything started with being a speech pathologist, working in nursing homes, and all we were dealing was dysphagia. Dysphagia as in severe difficulties in swallowing. But then missing was the part before the swallowing, including chewing. And by reading research in different fields, I realized, wow, we have been missing a very important function, which also connects us very tightly with orthodontists and dentists and TMJ specialists. So this is our connection, is actually mastication, chewing. And also the the functions that are in the same arena, which are bruxing and clenching and grinding and biting, all these movements, all these functions, we never realize how important they are for our body, and is because chewing is not just I eat something because I have to and then I forget. If you chew properly, you actually reduce the particles of whatever you're eating. You allow the salivation, and this translates with a much easier swallow. Plus, the saliva buffers your stomach, so you process the food much better. You have a transit time across your stomach much faster. So if you eat, for instance, before going to bed, you're going to have fewer chances of having GERD, for instance. Plus, the food is going to be readily available in your intestine to be for the nutrients to be absorbed. So chewing helps all this. But chewing also does other things. For instance, there are studies that show that chewing increases your attention. That's why when at courses or conferences, they always give you something to eat, not by accident. Also, biting is important because it helps you dealing with stress, for instance. So stressed out people tend to chew more because there is this biting process going on. They found out that closing your teeth also is a sign of aggression. So whenever you want to control aggression or you need to have that amount of aggression to face a situation, that's when you're just biting. There are studies that show that you're bruxing your teeth at night because that protects your cardiocirculatory system from sleep apnea. So there are all these unbelievable connections, seemingly so far away one from the other one, but they all come down to the same mechanisms, basically involving the chewing muscles, occlusion, and the temporomandibular articulation. And so in doing that, plus the stability of occlusion, the growth and development of the face is involved in chewing. So there are so many things that, to me, now it would be substandard of care to provide any type of myofunctional therapy that doesn't include chewing somewhere. Doesn't assess chewing, it doesn't treat it. So in terms of assessment, I always thought, yes, there are some complicated protocols, scientifically absolutely sound, but not easy to apply in small offices. And so thinking in terms also of awareness, the idea was, how can we assess chewing in a way that also helps the patient understanding what the patient is supposed to do. So I thought about this system. I'm sure someone else thought about it as well, but basically I give them some foods and I ask them, take a small bite, chew it, and when you're ready to swallow, don't swallow it, spit it. And so they spit it, and kids love it. adults is like, "Ugh," but then they like it too because, oh, I had no idea. That's when they say, oh, I eat so fast and I always get stomachache.
Right.
So then I tell them, now chew until the food in your mouth feels like a paste or almost like a thick veggie soup, and then spit it. So they can see side to side the food that hasn't been salivated enough, is not cohesive, it still has big chunks, it's difficult to swallow, and then something that is perfectly blended, very easy to swallow, and ready to be absorbed in terms of nutrients. And that sensory visual exercise actually works wonders in making the person, it doesn't matter the age, make them aware what's going on and how they can improve chewing. Then they can go home and do it on their own because they already experienced the first time, they already know what to look for. So they become their own therapist. That goes along with the changes in lifestyle that I was saying. If you have awareness, oh, I'm eating too fast, why are you aware of that? Because I just showed you that if you eat too fast, this is the result, and it's not good. If you take your time, then, and also you're going to lose weight, and you're going to be, and not having any stomach problems. So eat slower and make sure that the food is a certain consistency, which is a consistency, by the way, the speech pathologists say it's the safest type of bolus in dysphagia, which is, the honey thick, the puree thick, or whatever. So make it like so in your mouth.
I have a question about the idea of the smoothie. People are thinking, oh, this is easily digestible. It's going straight into my system. I can break it down. It has blue-green algae, etc. But what is it missing?
It's missing chewing, of course, and chewing is, if you look at certain studies, especially by Melvin Moss back in the 80s and 90s, he's a big proponent of the concept of the functional matrix, in which the muscles actually give the bones what they need and kind of direct the activity of the bones. I have nothing against smoothies. They're perfectly okay, as long as they don't become the only or the main way in which people eat food. Because by bypassing muscles, it's like, say, remember many years ago they had those devices that were vibrating you, and they were saying,
yeah, lose 50 pounds if you just sit there vibrating.
Right.
Yeah.
So it's the same concept in a sense. It's like, no, you have to put your effort, otherwise things are not going to work. So this is an extremely delicate and complex system, and the muscles need to work. If you don't work these muscles, in the long run, and there have been studies that show that if you have myofunctional disorders, of which muscles, hypotonic masseters and hypotonic temporalis are part of that pattern, in the long run, you are more likely to develop dysphagia, because the same muscles that protect you are the same muscles that are involved in chewing. So nature gave us this very important function. It's an incredible function, and yet so bypassed, because we are strapped for time. I only have 2 minutes. Even if I only have 2 minutes, I can't spend time eating something that requires chewing. I have to eat something very quickly. There goes the smoothie. Has a place and time.
Also, you could just add nuts.
Right. Or you can have nuts separately, because remember, nuts, if they are completely blended, then what's the point?
Or you add nuts that you have to chew in the smoothie, and you swallow the smoothie. Except if someone is at risk of dysphagia, then you have too many consistencies, and they can become, but that can become an assessment tool. You can ask people,
Do you have problems with soups that have veggies and meat, for instance? Or, you know, I don't know, rice and veggies. If they say, oh yeah, you know, I never eat that because, I don't know, sometimes they go down the wrong pipe, aha. Okay, so the approach is not to prevent the muscles from doing work, is to make them work. Not too much, because people who chew gum compulsively, then, you know, they have hypertrophy of the masseters. That's not good either. It comes with a lot of other problems. So you have to find the happy medium.
Right. Frequency, intensity.
And duration.
Yeah.
Right. All three have to be right. So if you have actually, ideally, your 3 meals a day and you have something chewable in them, then sure, you know, have a smoothie as a snack, or do you want to integrate whatever you're eating with the smoothie? Sure. But it always honestly makes me sad when I see all these kids with those pouches. It's like, what are we teaching our kids? What are we teaching them? Of course, if you imprint that in their brain, they're less likely to search for foods that are chewable. They're going to reject them, like, oh, it's too hard, it hurts my teeth, and
Right.
it does.
Right.
And why does that? Because you are not used to pound your teeth. So a big service that we can do to children to grow healthy and to grow with a proper structure that is good for occlusion, is good for sleep later on, is good for the nose, is good for everything. Make them chew as soon as possible. That's why I'm a big supporter of baby-led weaning, for that reason. Chew, chew, chew.
That's really interesting, because I am also very encouraging of baby-led weaning practices, with the understanding that there may be the population that may actually have some kind of deficiency.
Absolutely.
So there is that at the same time. It's
Right.
not just blanket statement, this
Right.
works for everyone.
Right.
But no one thing works for everyone.
Absolutely, that is true of everything, you know. In fact, even myofunctional therapy is not a cookbook. It cannot be a cookbook, because you have to look at the patient, what kind of problems the patient has, and also what is the body of the patient trying to tell me through these pathologies, through these symptoms. The symptoms are just, you know, a way of saying, I cannot do this, or I don't like that. So that's why an approach to patients must always be individualized, customized. It's like,
Specialized.
what is
Yeah.
your need? What are your symptoms? What are your complaints? What do you need? What do you need might be different than what the next person needs. So, but we have I like to say we have a vast variety of options in terms of assessment and in terms of therapy. We just have to pick and choose whatever works for that patient. So it's good to have variety.
Variety, and also understanding timing, which is a big piece of it. Do you have anything to say around orthodontic timing, working with orthodontists, how you're going to do the therapy, if there's expansion, do you stop? What's your understanding?
Well, first of all, ideally, I would like to see the kids before they go and see the orthodontist, because that's the time when I can figure out, okay, this kid needs definitely right away a big expansion of the palate, otherwise there isn't much I can do, because there is no room to reposition the tongue, the nasal cavities are just restricted, there are a lot of other issues. Also, this kid might need some help in terms of sensitivities, allergies. If they cannot breathe through the nose, there isn't much I can do either. Maybe they need a respiratory training. So, you know, in assessing all these things, then I would work with the orthodontist, like, okay, you start first, and then I'll come in, or let me deal with that first. Then when the function is better, or it's more optimal, or as optimal as possible, then it's going to be a breeze for you to do whatever you need to do. Professionally and personally, fewer things are in the mouth, the better, because the mouth is an extremely sensitive and complicated sensory motor system. And just think about when you have, I don't know, something stuck between your teeth and drive you nuts, or if you have you feel a grain of sand and all of a sudden, think about having an appliance in your mouth. Yes, you get used to everything, but not really. Your brain doesn't get used to it. It just learns to compensate. So I have to accept the fact that a patient, a child or an adult, for a period of time, they're going to be, in a sense, out of commission therapy-wise because they have these appliances, and I can't compete with those. Either there is room for the tongue or there is room for appliance. Almost never there is room for both of them. So that's why I have professional preference for some appliances that they have a minimum impact in the mouth. Like, they're just a simple wire or something. Like, I like the Alpha appliance. Okay, yes, I like the Alpha appliance. But there are similar appliances that help the patient grow with absolutely minimum disruption of this sensory motor feedback.
When the tongue is down, what are the effects?
Right. I always like to use the same example, and I like to ask people, don't you think that your fingertip is very sensitive? Don't you have all the sensitivity that you can? Yes. Then why can't you feel the air? And the air is everywhere. Why can't you feel the wind? You don't get fewer sensors in your fingertips. It's because you're missing the interface. So the moment in which you touch something, you interface this sensory system with something. So the tongue is extremely, extremely sensitive. Unless it interfaces with something like the palate, it's not going to express its full potential. Or it's going to express it against the teeth, which, mind you, maybe there is a reason for that. Maybe the patient has sleep apnea and the genioglossus is just pushing the tongue forward and getting the teeth out of the way. Okay. At that point, though, don't try to fix the teeth. Fix the reason why the tongue is pushing forward, seeking that important interface. So, and same thing for the cheeks. The cheeks are naturally interfacing with the dental arches. So if you start removing teeth, or if you start putting appliances or whatever, then that interface is missing. It's a sensory motor interface that is extremely important. That's why there was that a crucial article by Engelke, Nozel, and Jung, that the day I read it, I was floored. It's like my entire concept in myofunctional therapy changed, because it said one thing that is very important, which is when the tongue is in the right place, your lips are closed, your cheeks are wherever they need to be, and the soft palate sticks to the posterior part of your tongue, your mouth becomes a negative pressure chamber that keeps everything together, including your mandible, the mandible in relationship to your cranium, to your head. So everything is going to be in the right place. So it changed my concept of training the tongue, start with the tip and then the medium part of the tongue and then the back, as I know, do everything at the same time. Create that suction that is so important. And it's important daytime and nighttime. And so, it's important even if you are, for instance, if you're running, if you're walking, you have sensors that maintain the jaw in the proper position whenever your body is active. But if you keep your tongue up, you give an extra system to keep the jaw in the proper tension, so in a healthier position. So, as I said, I completely changed my approach to myofunctional therapy thanks to that article, thanks to other articles, but that was like, whoa, okay, I had it wrong, sorry. I had to go back and rethink everything. So.
The stereognosis research about open lip posture and tongue position being down, and the reduction of sensitivity because of that is another aspect that happens that I'm...
Right. And boils down again to the concept of interface. Because if you keep your mouth open and the tongue doesn't interact because it needs to stay low to help you breathe, so the tongue is not activated or is activated the least amount possible. So of course, if your lips are not activated, if the tongue is not activated, the palate is not activated, then whatever, whenever you put something in your mouth, that sensory system is not there to analyze it. That's why the stereognosis tests show that if you have an open bite, if you have an open mouth posture, if you are breathing through the mouth all the time, your entire sensory motor system changes. Therefore, the sensitivity to perceive shapes in your mouth is not there, which I would love to see something with regards to food. It's like, can you perceive a cherry with a pit better than a cherry without a pit? Or can you find a small fish bone, in the salmon? And that's another thing that in America we are kind of missing for fear of lawsuits, I think, is that we have fish that have no bones anymore, chicken that, has been deboned already because, God forbid, someone chokes. And I had a colleague of mine from Alaska. She brought this nice salmon caught outside her house, and she said, be careful because it has bonefish. So I said, yeah, no problem, I'm used to them. So I enjoyed it, and sure enough, you had to pick them up. And then I had a guest, and I said, this is the best salmon you will ever have, but be careful because it has some fish bones. So he proceeded to put a big piece in his mouth, and then he had no idea what to do with it, and he just...
It's almost like baby-led weaning for adults. He started too late.
And I realized a lot of people don't know what to do when they have something in their mouth, because here is the other thing. We've been taught that it is bad manners to spit, and we teach that from day one, except that spitting is a protecting mechanism. So when you have something in your mouth, you have two options. You swallow it or you spit it, okay? So the default mode, in nature is I spit it out. But we teach children that's not appropriate. You have to swallow it. So whenever you have something in your mouth that is risky, then you have this, this aversion for anything that takes a little bit more processing, and yet it's a protective mechanism. We are teaching children not to develop that.
Same for getting dirty and being fearful of getting food on themselves or experiencing the food with their hands, and we're using utensils. So,
or choking, he's eating a piece of meat. Fine, what's the problem? Actually, if it's smaller and it's big enough to obstruct the airways, then you should be worried. But if it's a big piece, like I will always remember, August, your son, with a nice
big chicken bone.
Yes, that's the way children learn. Because children, babies, toddlers, they are learning machines. And yes, first experience is going to be not so good. Oh boy, are they going to learn very fast. So, give them that opportunity. Don't take it away from them. Don't make them, weaker or unsafe in the sake of safety. It's like, oh, this is too difficult for you to chew, so I'm not going to give it to you.
Yeah.
It should be the opposite.
I think, get a little personal here, but the person who would lose the chewing contest is not my two sons either. Mark needs to go back to basics, start chewing his food, breaking it down and swallowing.
Unfortunately, it's very common with people who have very demanding jobs. So people who have a job that is very stressful, they have to go different places, they're running out of time. For them, eating is really about survival. So they're not thinking about, the optimization of food, optimization of chewing and swallowing. It's like, give me something. I had to just eat something, and then that's it. And honestly, guilty as charged, because sometimes even I grab the first thing that I can grab that I know doesn't require a lot of chewing. I have an apple, I have 3 cookies. Trust me, I'm gonna get the cookies because I only have 1 minute, okay? But I'm
Right.
aware of that, then I compensate. In the evening, it's like, okay, no, I'm gonna have this because I'm gonna have something with more consistency because I had to compensate.
Yeah.
And honestly, I'm doing okay. So.
I have a question about protocols in general, because there's a big part of our course that was created by you in looking at protocols in myofunctional assessments, and which are multidisciplinary. So can you talk about the protocols that you have included in our book as well?
The reason why we should use protocols is because one of the criticism that was done to myofunctional therapists in the very beginning was that you are not scientific enough. You don't know how to do evaluations. So the idea was, okay, let's start with validated protocols, so protocols that went through a rigorous analysis by researchers, and let's apply those. And because some continents or countries are much stronger in the scientific support of myofunctional therapy, some of the very first protocols that I wanted to share with others were coming from South America. So we have a breathing protocol from Franklin Susani Bar Chavez, and so that's a great protocol. We also have protocols for lingual frenum by Irene Marquesan and Roberta Martinelli. We also included a multidisciplinary quick and dirty assessment. It's supposed to be 1 page. That comes from Spain. We have also a collection of smaller assessment tools for sleep disorders, for posture, so that we start with that. And then clearly we try to use exercises in therapy that by themselves, directly or indirectly, they have a scientific support. So whenever we present an exercise, first of all, we are asking why. What does it do? How does it do it? Is there anything else that we can do? So the book wants to stress the importance of having a scientific approach, not to minimize the experience that therapists of any kind bring to the picture, or how the patient feels. I'm a strong proponent of the placebo effect. If you think it's going to work, it's going to work, and that's important for patients to stick with a certain type of therapy. But at the same time, I really want patients to be involved in their own therapy, believe in it, so that they, as I said before, so that they can transition from therapy, whatever therapy they're doing, into a lifestyle.
Also, I know assessment protocols are really a bridge to share the validated science of what you've found in your assessment with a referring doctor. So somebody who may not be as familiar with frenulum restriction,
Right.
It might be another bridge to share the results of the Marquesan protocol and have it because it's validated, there's a certain credibility in your findings.
Right. That is one of the important aspects. Another important aspect is because a lot of these protocols came from Brazil, they were designed by researchers, and their purpose was, let's have something that if we all share, we all are going to use the same material, and so we can then eventually pool all our results, therapy results, and create a meta-study or create a much larger pool of subjects, of patients. Therefore, whatever results we're going to get are going to be more salient than if we have just a pilot study with 10 patients. So the idea was, let's have something that everybody agrees, and we can then pool all our information. So for that reason alone, we just decided to include, several protocols.
You talked about exercises and the why, and that's one piece of this book that I have enjoyed so much, is your critical, curious mind coming through the material and how you found the answers and why that is. And you've always looked for the research to support and the claims that are being made with the science, and that's what makes you such a wonderful clinician and teacher. But talking about the facial muscles, I know that's another part of your investigation. What have you found that's of note?
Right. When I was actually working in updating this book, I realized that all my teaching years, I was always telling the students, we're going to talk about the facial muscles, but only these. Forget about the other ones. Because I myself never paid attention to the other muscles. Like, okay, if they do something, I'm not really interested, because I thought that they have nothing to do with chewing and swallowing, in a sense. So when I was actually preparing the chapter on the muscles and their function, I realized, wow, I missed a huge contribution of these muscles to actually breathing, chewing, posture, vision. And so instead of looking at them individually, like you do in an anatomy book, this muscle has this name, the origin is here, the insertion is over there, and when it contracts, it does this. It's like, yeah, so what? So now when I teach about the facial muscles, I want people to understand that these muscles are different than just these muscles, and they're different than these muscles. For instance, these muscles from the upper lip all the way to the zygomatic and back are muscles that we actually use in helping breathing. Have you ever seen those children that go?
Right.
If you try, it's going to enlarge your nostrils, right? Mm-hmm. So you get more oxygen. But it's not just enlarging, in a sense, your nostrils, is that you have to use all these other muscles. See? So these muscles actually, and dilating the nostrils, and even position like this. If I do it, I'm also expanding my airways. So all of a sudden I thought, wow, yeah, muscles are actually serving very basic functions, which is breathing, which is chewing or jaw position, which is important also for the position of the tongue. And all these muscles, they actually help you seeing. You can see far away, you can see in the darkness, you can protect your eyes, you can read better. So all these things we never think about, and yet we are working with patients. How many patients come to our office because they have maybe, breathing issues or orofacial issues, and then they can't see very well. And then, in fact, there is a portion of a chapter written by Pasqualina Andretta, a speech pathologist from Italy, and the emphasis of her therapy is vision therapy vis-a-vis myofunctional therapy and posture. Because if you always have a posture like this, then you have to lift up your eyes, because your eyes always have to be at the level of the horizon. If you have a postural problem and your head is always like that, then your eyes have to adjust constantly. We never pay attention to that. And going back to your question, in my professional life, I have to eat a lot of humble pie, as they say. I have to change direction of my profession, sometimes 180 degrees. It's like, wow, I'm doing the wrong thing. I have to do exactly the opposite. It takes courage. It's easy to say, whatever I've been doing, it's fine, I don't need to change. But no, with new science, you need to make sometimes drastic changes. So just like when I realized the importance of the facial muscles, I realized, wow, I'm sorry that I did not realize that sooner, and I'm sorry I didn't have the chance to share this information with the students. But hopefully from now on, you know, they can look at the face in a different way.
I think we all have that feeling, either as a parent or somebody who didn't have the information at the time,
Right.
and then huge remorse, guilt,
Right.
wrapped up
Right.
into the knowledge that you gained.
Right.
So you get a pass, because I know what you do is you bring so much insight into the research element. You read research because you enjoy it, and it's your pastime.
It is.
If you're sharing some tips about how to look at research for people who are in the field, are there any just pivotal things that you can share about that?
Well, yeah, it takes critical thinking, first of all, because any subject you can find almost all the time equal amount of science in favor or against, which is okay. But that's when you have to look at the details. You have to look at what kind of subjects did they use. Are they comparable? What kind of methodology did they use? Is it comparable? Know all the biases in science, in publication. Articles that get published usually show a correlation or something. Those who don't show anything don't get published. So, or those who are, yeah, could be, or maybe not, don't get published. So beware of only good results. You know, sometimes you have to know, okay, so what if I don't get results? Number one. Number two, yes, this study shows incredible benefit of using this exercise with these patients. Who are those patients? Are my patients similar, or is this a group of patients that have, I don't know, Parkinson's disease? I'm just saying, okay? Then, yay, works for them, doesn't mean it's going to work for my patients. So you always have to look at any article in a critical manner. You have to really look at the details, and sometimes the details are buried in excruciating details by themselves. So you have to think about that. You have to think, okay, how can I apply this? Because there are a lot of very interesting articles which I love, but then I'm thinking, okay, and, you know, for instance, if it's an article about an amazing device that measures muscles, I'm happy. I can't afford it. So, you know, what good does it do to me? I'm happy for the scientific community. They have one more tool, but in my office, I'm not so happy. So I tend to look at something that I can easily apply. The other thing is, think outside the box. Some of the greatest articles that I read and that were more useful to me, they were not published in journals that had to do with speech pathology or myofunctional therapy. They were actually published in journals as far as neurology, physics, I don't know, movement disorders, whatever. So don't be afraid of looking at someone else's profession's journals, because they're going to give you the answer much faster and more complete than if you're struggling looking for an article in speech pathology journals or whatever other journal. So, you know, think outside the box. That's where you're going to find the answer.
Definitely. Okay. I think that's what brought you to myofunctional therapy. but I'm curious about the road in and where you learned and where you studied and how you got your knowledge.
Well, before I go into how I got over here, I want to say one thing. I'm really moving away from the concept of myofunctional therapy because I find it to be too limited, and it kind of excludes a lot of other professionals. So I'm moving towards the concept of applied myofunctional sciences, because then it doesn't matter where you're coming from. If you have a piece of information is good for me, good for my patients, I'll take it, I'll apply it. Or I know you do, so I'll refer you my patients because I can only do so much. So that's one thing. But how did I get to this point? Many years ago, decades ago in Italy, when I was working as a dental hygienist, I was actually working for a functional orthodontist. And so we were bouncing off ideas. It's like, okay, so the tongue does this or the lips, but how can we make the muscles work for us? And back then there wasn't much. The only information available was actually in the United States, was actually Daniel Gardliner, who went all over the world teaching people about myofunctional therapy. And when I heard about it, I couldn't believe it. Wow, that's the answer to all my questions, even questions I didn't have yet. But my knowledge was limited, so I decided I'm going to go and get a degree in speech therapy in Italy, which I did at the University of Padua. And I had, as one of my teachers, someone who has been applying myofunctional therapy in Italy, Pasqualina Andretta, who also collaborated in this book. And then when I moved to the United States, I redid my schooling again, but I always held on this thirst for knowledge in terms of how do the muscles work and how they interact with the bones, and et cetera, et cetera. And in the process, I really, not only I learned a lot about how the muscles actually influence the bones, and in the long run. In the short run, of course, if you expand the palate, then you're gonna make the muscles work the way you want. But in the long run, in the growth and development of a person, muscles always come first. So that was, to me, that was an important revelation. An important revelation was also the pyramid of needs. We need to breathe first. If we don't breathe, we are dead. So the body changes based on breathing. That's something I learned here. I learned from Patrick McEwen, also part of this book. Then we moved from, okay, breathing during the day, it's fine, but what about during the night? Sleep apnea. Boom, another area in which I thought, wow, myofunctional therapy can really do a lot. And indeed, some researchers like at Stanford, like Professor Guimino and others, or in Brazil, they took that concept and they really produced very strong research that now is helping us. And so it has been a constant movement, a constant progression in realizing that myofunctional therapy can be applied in so many fields, more than the ones I knew in Italy. And there is no end in sight. So I'm very, very excited. Part of the passion came by teaching, because when you teach, you have to know what you're saying. You have to be prepared to be questioned. You have to be prepared that some people could have an opposite take. So you have to be respectful, listen, be ready to change your mind, ready to say, sure, your proof is stronger than mine, so I'll review my own position. And again, think outside the box, and think also what is really working for patients, or what is not working, and why not.
You painstakingly went through many revisions to get it to this point, and I wanted to ask you about the process of the team working on this book.
Yes, not only we had several contributors in Italy, some people I even never met, but we also have a lot of people helping me with the English version because, as you know very well, my native language is Italian, so don't trust me with English. So I was able to actually look at the content, but in terms of helping me out both with the content and with the form, I actually had a lot of help. Not only Sabina herself helped me out, Hila Robbins and her husband, they were so gracious to help me out, and you know her, she's a fabulous pediatric orthodontist, so she was invaluable in reading the book and suggesting, you know, adjustments. I had a big contribution from Dr. Joseph Seamus and his team. His expertise in facial pain, and he's a qualified medical examiner, so his use of language and all the suggestions he made, they were very precious to me. And of course, I had so much help from the publisher in Italy, who provided me with a little team of people that could actually come up with the proper pictures, the graphics, which are so important. And that's also what makes this book different from the previous Italian version. This one has much more illustrations, which are helpful because we are, you know, visual society. So especially for difficult concepts, nothing works better than a nice picture or or a graphic description. So that was very nice. And of course, I'm very, you know, I'm pleased that Mark and the AOMT actually decided that this book was valuable enough. So he encouraged me to complete it and to make it ready. And I do believe it's a good book as a textbook. So he thinks the same, so that's very invaluable.
It's synergistic with our whole curriculum, and it really goes back to you and how you've been leading the charge for so many years.
Thank you, but I'm telling you, I learned from a lot of people. It's like I tried to distill all this knowledge that was passed on to me and passing it on to someone else. So I really hope that this book is going to be good for a lot of students, a lot of people, even, you know, even students who enter a profession. I think they're going to find it interesting because it's not written with an overly complicated language. It's like, okay, let's keep it, you know, scientific, but not too crazy with lingo. So that was important. And the Raffaele Grandi, who's the publisher with Eddie Hermes, he also, because he publishes other medical books, he was able to steer me towards one language rather than another one. So, you know, I received a lot of support from a lot of people. And on both actually more than both continents, in, you know, in Australia, in South America, in Europe, in Asia, everybody gave me a hand. So this is really a team effort of which Sabina and I are simply, in a sense, the most visible elements, but behind us there is many people.
Well, it takes a movement to really affect change, and I love what you said about applied myofunctional sciences. It really is a multidisciplinary team, and the therapy is one element, but it transcends so many different functions. We really have to incorporate different modalities and really pass the buck when it's appropriate.
And I'm so pleased that in working on this book, I really had the support of people who are giants in their own profession. So, you know, they are really someone that I do admire tremendously, I do respect, and I'm humbled that they said, sure, I'll help you out. You know, it's like, thank you. So, you know, kudos to all these people. And whomever gets the book, they can read all the names in the beginning of the book. Each one of them has been really precious. So, yeah.
Thank you, Licia.
Oh,
this is
thank
such
you,
an
Samantha.
accomplishment. It's such a gift. It's such a
Thank you.
tool that we can all learn from and cement what we may have already seen or understood, but it's really a reference tool that is really timely.
Thank you. Thank you so much, Samantha, for this opportunity. I'm
Pleasure.
grateful. Thank you.